and all my D-Genius colleagues here. I've fallen in love with the first slide of Surjit, or slide, the dog with the burger there. And I think when the topic was given, even I was a little confused. What do you mean by the drug holiday? Do you mean a short holiday or a quarterly holiday? Or is it a long holiday? Because uh, in our patients, one challenge we all face is the compliance. Even before we prescribe a holiday, they themselves take a holiday in different, especially it applies especially GLP-1 analogs. Most of them you would think they are compliant with the drugs, but when you probably go into the history, they would probably said, no, I've missed it here, I've missed it there, cost may be a constraint. Let me give a balanced view on I think Sir has beautifully pointed out the points where we need to pause, but we need to understand the physiology and the pathophysiology. I think Sir has pointed this, but it's very important. And one more scenario where we face this drug holiday is statin therapy. I think a lot of us would see 3 months, 6 months, they would come, they see their lipid levels lowering. They'll say, doctor, can I stop the statin? You understand that statin, not only just for lowering the lipid levels, it's also for the pleiotropic benefits. Similarly, when you talk about the obesity drugs, especially the GLP, obviously it has all the other pleiotropic benefits which we need to understand. Obesity, as recognized by most of the societies as well as the bodies, is a chronic, complex, and relapsing disorder, multifactorial, not only about excess calories and reduced physical activity there. We now understand the genetics, the epigenetics, the psychological medications, as well as the hypothalamus role in the weight management. And we have moved from a calorie balance to a neuroendocrine regulation, and that's why this understanding has definitely helped us in better pharmacotherapy. Obviously, one important issue is the adipose tissue, and we know that in obesity, there is dysfunction of your adipocytes, which is a key driver of your complications. Adipocytes have a dysregulated production of your adipokines, which can drive insulin resistance and also increase your inflammation. And we Indians, we know that even at a lower BMI, we tend to have a high visceral fat, and visceral fat is a leading factor for all your chronic complications. As Sir has already mentioned, set point, but again, when you see in detail, we need to understand that plateau is not drug failure. That's because we need to understand the biology there. Whatever the weight loss, maybe drug-induced or a medical nutrition therapy, when a person loses 4 to 5 kgs, even before whatever the mode it may be, the next 4 to 6 weeks to lose those extra 2 to 3 kgs is extremely difficult. That's because we know that body also fights back, and there is a kind of a dysregulation in both your ghrelin as well as your leptin. This is where exogenously, when you go with these therapies, especially the GLP or the dual agonist, definitely they help in regulating your satiety, but it's not a cure for your dysregulation. It manages as long as you're on this therapy. Obviously, the withdrawal effect does have a yo-yo effect, and obviously removing the exogenous GIP signal removes this break, and the biology definitely resets the patient back to again the hyperphagia and the weight regain. So obviously, when they lose weight and when they stop the therapy, in spite of sustaining the dietary interventions or cutting down your carbs or you're increasing your physical activity, we have seen all these trials. Even if you talk about those who are looked at only as a lifestyle and diet, we have even the direct trial on the remission of diabetes. The biggest challenge we all face is the sustainability. The second thing is obviously when you stop an intervention, there is obviously a risk of regain. And there is almost a hormonal and a neuroendocrinal regulation for this. And we all know the modes of eating. We have the homeostatic eating, we have the hedonic eating. Biggest challenge we all face, I think all of us would face in the next 3 days, is the hedonic eating which happens. So that is something you would ask a lot of our people who are on these drugs. Whether it is this function, that function, whatever it may be, thanks to these drugs, I think they kind of resist what they eat. But obviously, when they are off this, you tend to have override your senses, and definitely there is hyperphagia. We have a lot of data there, what happens, and I think Sir said that there is not much trial on the reset or the pause, but we have had the initial drugs. I'm not talking about a complete, first we'll start with the complete cessation, then we have the intermittent one. When you look at this is the paper in the BMJ, and they looked at weight regain after cessation of all the drugs. It not only included just the GLP and GIPs, it also included the older drugs. And what they said is, obviously when they stopped, we know that there was an average weight regain at the rate of 0.4 per kg, and most of your A1C, the cardiometabolic risk factors again picked up after 1.4 years after stopping the drug. The rate of regain after the cessation was faster once these drugs were stopped, and the more challenging aspect is the cardiovascular, cardiometabolic risk which is associated with stopping these drugs. And it's not just about the weight. As I already mentioned, these drugs today, both ADA, ESD, also talk about the cardio-renal safety with these drugs, the pleiotropic benefits of the GLP and the GIP, and we don't know that we don't have a structured trials to show the intermittent pausing, what is it going to have on these pleiotropic benefits. And weight cycling definitely subjects the patient to renewed cardiovascular and metabolic stress, which can potentially worsen your inflammatory markers. We had the step 4 trial. I think here I think we know this in semaglutide. There were people who continued semaglutide. At 20 weeks, it was stopped. There was a placebo group which continued to have calorie-restricted diet as well as increased physical activity. They're almost matched in both the things. But when the drug was stopped, there was almost a 6.9 increase weight in the. But that was almost at the end of 72 weeks. But we don't know what happened after that. So almost there was a weight regain in the group which stopped the drug, and this not only holds good for semaglutide, it's happened even with the SURMOUNT-4, and even the step 1, which was the extension of your the first trial, the similar rebound happened whenever the drug was stopped. So lifestyle intervention alone was not insufficient to maintain the benefits achieved pharmacologically, and you can see the yo-yo is definitely not good in these in managing your cardiovascular risk. So there has been definitely a consistent failure of holidays, be it the step 4 or the step 1 extension with your semaglutide or the SURMOUNT-4, and also the older trials with liraglutide was also shown that when you stop it immediately, definitely regain happens. But the question here is, do we have enough data on the intermittent stopping? I have a couple of slides to talk about the intermittent pause, but I mean the mathematical modeling. But one important take-home message is, if you're planning to start somebody on these drugs, you need to counsel them understanding the chronic nature of these therapies. Stopping them immediately can have adverse consequences. This is the scale of obesity, and I think this is a recent paper which was published, and people talk about the cost, and we know the indirect cost which piles up with obesity and also the obesity-related complications. So with such high prevalence, the luxury of a drug holidays definitely becomes a public health risk, and especially in a country like India where you do have the availability of biosimilars and the generics which is going to happen. I think we definitely have much more. When you talk about financial constraints, I think we are definitely still much better off as compared to our Western counterparts. And if you look at some of the guidelines, be it the ADA, it says that obesity medicine should be offered as your initial treatment or approved for your long-term treatment. Continue obesity medications after reaching your treatment goals. Discontinuation often results in weight recurrence. Cessation is advised for weight-promoting medicines, but not for your obesity drugs. Couple of slides for my sir. I think there are some mathematical modeling which are shown about this intermittent therapies of your GLP-1s. And this, they basically looked at, this is not a clinical trial, it's a mathematical modeling of the PKPD which they looked at. They looked at the reduced frequency, that is reduced frequency of semaglutide. Instead of giving it weekly once, they have given it once in 2 weeks. And what they found out was the efficacy was almost till 72%, and the cost obviously came down by 50%. They also looked at terzepatide spacing. Here they increased the dose from 5 to 10, but the spacing was there. And once they reached the maintenance dose of 15 mg, they were able to use the spacing almost once in 10 days. And even at this spacing, there were almost 100% efficacy at a 30% cost was much lesser. Spacing is definitely a viable maintenance strategy if cost is a barrier. Stopping is not. But again, long-term clinical data on the CV and the metabolic benefits must be explored before we advise to our patients. Again, the paper here on the maintenance, how to go about it. Patients definitely tend to have these drug holidays in which they pause the drug intermittently for special occasions, but there is very little literature on this. The effects on weight, cardiovascular health, and other parameters of decreasing the dose or pausing of the GLP-1 agonist is an area where evidence-based studies are needed. What is definitely required is much more research in these, the intermittent or what you call as the drug holidays. We need to understand who are the right candidates where you can afford these drug holidays. And when you talk about these maintenance strategies, you need to understand once they reach their target weight loss, then you need to understand what tapering dose or what spacing is required. But also we need to understand the other health implications, mainly the off-ramping on the cardiovascular risk factors as well as your body composition changes. And also obesity with diabetes, when you do this yo-yo, the glycemic control can also go off the track. So, glycemic variability is again a bigger challenge. So you need to understand who is the right candidate to go on these kind of strategies. And during the pausing, you need to have a proper interventions on your diet, exercise, as well as peer support group. So to conclude, obesity is a chronic disease. Long-term pharmacotherapy is typically needed after the goals are achieved to sustain the benefits. GLP and the dual agonists target the dysregulated neurohormonal systems that cause weight gain and prevent sustained weight reduction. We have the evidence. We have the step 4 and hormone 4, which have shown that when you stop, there is weight regain, but we don't have conclusive evidence, especially on the pausing, which spacing is much better. Definitely, the yo-yo definitely puts you at an increased risk of cardiovascular and metabolic risk. And in an Indian context, where there is a high prevalence, considering the magnitude of the problem of the NCDs, and mainly the problem with the compliance with medications, advocating drug holidays can be deleterious. So a proper consideration and choosing the right patient is important. And to counter Sir's first slide of the dog with the burger, I have my elephant here with all the burgers sitting in there, and we need the help of these pharmacotherapies. And plateau is maintenance, not a failure. Thank you.